Bubble CPAP. So in the next 30 to 40 minutes, we'll cover this topic under the following headings. We'll talk about what are the indications of using CPAP in day-to-day neonatal practice. Then we'll talk about what are the settings of CPAP which we use in different diseases in newborns. And then we'll talk about what is the evidence. We will talk only about some of the major evidence behind use of CPAP in various disorders. And finally, we'll talk about how to wean a baby once the disease process is passive. So before going to the main topic, we need to know what is respiratory distress. The newborns tend to have higher respiratory rates, usually around 40 to 60. And when this respiratory rate is more than 60, we call it tachypnea. Then there is something called retractions, where there is indrawing of the chest, especially the intercostal muscles. Usually it doesn't happen in a normal baby, but once the lungs are stiff, as we see in RDS syndrome, because of the stiffness of the lung and the negative intrapleural pressure, there is indrawing of the intercostal muscles, leading to retractions, which can be suprasternal, intercostal, or xiphoid retractions. Then nature is always the best medicine, and in order to prevent the end expiratory collapse, the nature has a ready-made CPAP in the form of grunt, which is seen at the end expiration, where the glottis closes so that it doesn't allow all the air to escape during expiration, and some of the air remains in the alveoli, and thereby it prevents its collapse. So again, it is a protective mechanism, and there is something called as nasal flaring, where we see dilatation of the LA nasa. Again, this is a normal natural response to respiratory distress, where the baby tends to increase the diameter of the airway, thereby decreasing the resistance and the work of the breathing. In any newborn, whether he is term or preterm, if we see 2 out of these 4 signs, he qualifies as a baby with respiratory distress. And remember, dear friends, that respiratory distress is one of the commonest indication for babies to get admitted in an ICUs. Moving further, it is always good to be objective in your assessment, because one may not agree with the other, and there is always interpersonal variations. Therefore, to come down on those interpersonal variations and be more objective, it's always good to use some objective scale. For example, in respiratory distress, we use Silverman-Anderson score. Why we use this score is because it has been validated both in term and preterm babies. And as you can see in the picture to the left, out of the 5 components, that is upper chest retraction, lower chest retraction, xiphoid retractions, dilatation of the nasa, there are 3 components which tell us about the FRC, whether it is adequate or inadequate. And the score for each of these 5 ranges from 0 to 2, where 0 is minimal distress and 2 is the severe distress. The only point which I would like to highlight in using this score is the differentiation between the upper chest and the lower chest. It is not similar to what we see in radiology. Here, we draw an imaginarily mid-axillary line, and the chest above that is called as upper chest, and the part of the chest which is below that mid-axillary line when the baby is lying supine is known as lower chest. And it is always best seen by standing on the side of the baby and bending to the level of the baby to assess the retractions. Apart from this score, one should always remember that do not judge the baby's respiratory distress based on the single scoring. It has to be continuous. It has to be baby has to be serially monitored. There was always look for the trend, whether it is worsening or improving. One of the important things to assess respiratory distress in a newborn, which is missing in this chart, is sensorium. Sensorium, an obtunded or a baby who has altered sensorium, is a sign of impending respiratory failure. No matter what the score is, it's always a baby who may fail non-invasive ventilation and will go on to require mechanical ventilation. Because for non-invasive ventilation, the first and foremost condition is that baby should have good spontaneous respiratory efforts. The other thing is, score again should not be done in isolation. We should always consider the underlying respiratory support. For example, if the score remains at 6, but the respiratory support FI2 has gone from 30 to 80, or the CPAP ratios have gone from 5 to 7, we cannot call both the babies having the same kind of respiratory distress. So always talk about these things apart from the scoring. That is the trend of, is the baby improving, worsening, or static? What is the sensorium? And the last but not the least, degree of respiratory support. The other basic principles, because newborn cannot be managed in isolation, we have to take care of some basic things. Antenatal steroid is something which is cost effective, beneficial both in decreasing morbidity like RDS as well as mortality. It also decreases the incidence of IVH, early onset sepsis, and need for mechanical ventilation. This is something which is the right of each and every premature babies, and it should be given to them. Remember, just like any other drugs like inotropes, we are very cautious about using inotropes, steroids in our NICU. Similarly, remember that oxygen is not a tonic, it's a drug. Therefore, its dosage, duration matters. Try to use oxygen as in minimum possible dosages and for minimal duration as possible. And the best way to do it is use a blender. Even during resuscitation, one should always use a blender, and one should try to target a saturation of 90 to 95. That is a pre-ductal saturation of 90 to 95, irrespective of the gestation and irrespective of the disease process. A baby who is on oxygen should receive oxygen by blender. And the other important thing is that baby should be regularly monitored with a pulse oximeter to know the saturation. No matter how high-end machines you may be using, but if you are not using these two basic equipments in your NICUs, you are not going to get intact survival. And last but not the least, majority of the good centers in India have burned their fingers. So all premature babies who are less than 35 weeks or late preterm surrogate or who had a very turbid course in the NICUs should undergo ROP screening at 3 to 4 weeks. Now, why we are talking today about CPAP, why we are not talking about mechanical ventilation, although we have so many hi-fi modes to choose from, which includes SIV, PSV, and now we have something called HFO with VG. It's because when we compare CPAP with mechanical ventilation, we all know that it is non-invasive. But what is the evidence? The evidence is that when we compare CPAP with the mechanical ventilation, the incidence of bronchopulmonary dysplasia decreases by 11%. CPAP in comparison to mechanical ventilation also decreases death or bronchopulmonary dysplasia by 11%. Also, the need for mechanical ventilation and need for surfactant, which is in fact one of the most costlier drugs in neonatology, comes down by half. That is, there is 50% reduction in need for mechanical ventilation and use of surfactant. And this does not come at added cost. That is the rate of complication which many may fear in using CPAP. That is, air leak and IVH grade 3 and grade 4 are similar. The use of CPAP is not only effective, it is safe. That is, it does not increase the risk of complications like air leak and IVH. So CPAP should be the first and foremost modality for all babies with respiratory distress in our NICUs. Now, how does CPAP help a baby with respiratory distress? Now, what happens during normal inspiration is that the air goes inside the lungs, the diameter of the airways opens, and the lungs get filled with the air. After filling of the air, all the alveoli are surrounded by capillaries. There is continuous gaseous exchange, that is, oxygen goes into the alveoli, and carbon dioxide moves from capillaries into the alveoli, and we exhale that CO2. Now, the problem lies during expiration. What happens during expiration? As we exhale, the gases pass out from these alveoli into the large conducting airways and finally to the atmosphere. Because of the surface tension, these alveoli tend to collapse at the end expiration. This is especially true for premature babies who have deficiency of surfactant, because surfactant is an surface active agent which decreases the surface tension of the alveoli and prevents the end expiratory collapse. But if the lungs are deficient in the surfactant, as can be seen in premature babies leading to RDS, the alveoli collapses at end expiration, leading to atelectasis, which leads to something called as atelectotrauma, due to which there is leakage of the fluid into the alveoli. And finally, there is vicious circle which leads to inflammation, decreased surfactant deficiency, again leading to atelectasis. Now, what happens when we are using CPAP? We are using a constant distended pressure which keeps the airway distended both during inspiration and expiration. Thereby, it splints the airways and prevents that end expiratory collapse, leading to improved exchange of gases, and better oxygenation. Now, we should also remember that surfactant and CPAP go hand in hand. This is well explained by the law of Laplace, which shows that T, where that is the tendency of the alveolar to collapse, that is the inward pressure which causes an alveolar to collapse, is directly proportional to surface tension. Here T is surface tension, and is inversely proportional to the radius of the alveoli. Now, what happens to the radius when we give CPAP? The radius increases. Therefore, once the denominator increases, the tendency to collapse, that is the pressure which causes the collapse of the alveoli, it will decreases. And when we use surfactant with CPAP, here T is the numerator. So that surface tension will again decrease. So by giving surfactant, we are decreasing the numerator, that is the surface tension. And by giving CPAP, we are increasing the denominator. That is, we are increasing the radius of the airways. So both work hand in hand, and that decreases the tendency of these alveoli to collapse and an expiration. Therefore, one should always use surfactant along with the CPAP in babies who have RDS, who have moderate to severe RDS. Apart from this, the CPAP also splints the narrow airway, which have again tendency to collapse because of the narrow caliber. By splinting the airways, it decreases the resistance, it decreases the work of breathing. Therefore, it improves PQ mismatch, which happens because of the atelectasis, and thereby it reduces the intrapulmonary shunt. Also, because it splints open the airway, prevents their collapse, it decreases the incidence, or it is beneficial in treatment of obstructive apnea. As the CPAP distends the lungs, it also distends the pleura over the lungs. And this pleura contains J receptors. And once these J receptors are stretched because of the constant distension by the CPAP pressure, they send an input to the respiratory center, which increases our respiratory drive. Therefore, it is also useful in central apnea. All these mechanisms go hand in hand, and they improve oxygenation, decrease hypercarbia, decrease VQ mismatch, and decrease work of breathing. Now, in addition to these mechanisms, there is also postulate that the bubbling which happens in the bubble CPAP, it acts as an oscillation, just like in HFO ventilation. And these oscillations are transmitted to the chest wall, and they also help in gases exchanging and decreases work of breathing. Now, no therapy is without side effects, especially if we do not use it in proper way. Same is true for CPAP. There is something called as optimal CPAP. We need to use CPAP in a range of 4 to 8 centimeters. Some centers even use as high as 10 centimeters. But the important thing to remember, as can be seen in this diagram, is that the pressure should not be low enough. They should be enough to distend all the alveoli, where we get an equal increase in volume per unit change in pressure, as can be seen in the steep portion of this graph. That is the optimal CPAP. Now, if you go on beyond 8 centimeters of mercury, that is reflected by this point, which is also known as upper inflection point. If you go on increasing pressure beyond this point, you will hardly gain any increase in volume, but the risk of complications like air leak, decrease in cardiac output because of the increased intrathoracic pressure will be more. So it is always good to use an optimal CPAP between 4 to 8. Do not decrease it below 4, because that is again going to cause atelectasis, because it is not enough to open the alveoli. FRC will not be established. And do not go beyond 8, because the risk of complications will be more than the benefit. The other important thing to remember is that both in the low pressures, that is pressures of below 4, and high pressures, as can be seen commonly, the low pressures, low volume lungs are seen in RDS, and the high volume lungs, as can be seen in meconium aspiration syndrome, air leaks. Both these extremes of lung volume, that is underinflation and overinflation, they lead to increased pulmonary vascular resistance. And once there is increased pulmonary vascular resistance, there is decreased blood flow to the lungs, leading to hypoxemia, that leads to vasoconstriction, and again a vicious circle will start, and baby will end up in hypoxemic respiratory failure. That's why again it is emphasized that we need to optimally dilate or expand these lungs, and we should always ventilate or expand this lung above lower inflection point, where we get an equal increase in volume per unit change in pressure, and we should avoid overexpansion. Now, what are the clinical indications? For premature babies, the best therapy for any form of respiratory distress is CPAP. For babies who have respiratory distress at birth, they should be started on delivery room CPAP. with the help of TPs. Now in term babies, we can use CPAP only, which we may use CPAP in all the babies, but it is good to use CPAP whenever they have moderate to severe respiratory distress or they have retractions. Retractions are a sign of low FRCs. Therefore, apart from oxygen, they also need pressure. Apart from these, post-extubation CPAP is found to be useful in decreasing the rate of reintubation, especially in babies who have less than 1.5 kgs. As already discussed, it is also beneficial in apnea. But remember that CPAP is not useful as an alone therapy, but it has to be used along with the caffeine. So for apnea, caffeine and CPAP remain the treatment of choice, and majority of the babies can be salvaged with these two modalities. However, remember, for CPAP or any other non-invasive mode of ventilation, baby needs to have good spontaneous respiratory efforts for that CPAP or other non-invasive ventilation to work. Without it, no non-invasive mode is going to work. Now, how do we define the ideal CPAP settings? For us to say that a baby is stable on CPAP settings or the CPAP settings are adequate, the vitals, that is, there should be no tachycardia, no apnea, baby should not be fighting, he should be pink, his CRT should be less than 3 seconds, the retraction should subside or they should be minimal. If they are still there, that means the pressures which we are giving to the baby are still low. Saturation should be within 90 to 95, as we have already discussed. The lungs should be well expanded, that is, they should not be under or overinflated. How we define a normal inflated lung is that an X-ray should show air spaces of 6 to 8. If it is more than 8, it is overinflation, and if it is less than 6 intercostal spaces, it is an underinflation. Then blood gas should show a normal milieu, that is, there should be no respiratory acidosis or hypoxemia. Then coming to the settings of the CPAP, the first and foremost is the CPAP pressure, which we usually set between 4 to 8 centimeters of water. Then the other knob is a FiO2, which is done with the help of a blender, and we can set anywhere between 21 to 100%. It is good to start with a low FiO2 for around 30%. And then depending on the saturation, we can go on to increase it to 100%. Then the third mode is flow, that is between 3 to 6 liters. And how do we know that the flow is adequate? There should be a continuous bubbling both during inspiration and expiration. The other two modalities or the other two things which we often ignore but are equally important, like the previous three, is the humidification and temperature. Remember that without humidification and warmidification, the gases or the CPAP will not work. They are equally important as your pressures and oxygen. It should always be 100% relative humidity, and temperature should always be equal to the body temperature, that is 37 degrees Celsius. Now, how do we set pressures? We usually start with a CPAP of 5 to 6, and we increase till the retractions are subsided or they are minimal. The other thing to look for adequate pressures is again an X-ray showing well expanded lungs within intercostal spaces between 6 to 8, and the saturation should be between 90 to 95. If there are no retractions or the chest is not overinflated, it is not looking a barrel-shaped chest, that means we are giving adequate pressures. Retractions means the pressures are less, and overinflated or prolonged CRT can be because of the high pressures, because of the decreased venous return, because of the high intrathoracic pressures. Then FiO2, simplest way is to look at the pulse oximeter and target saturation between 90 to 95. In blood gas, the PO2 in preterm babies should be between 50 to 70. In term babies, we can accept slightly higher, that is 50 to 80. Flow should be started with 3 to 4 liters. It should be enough to generate a continuous bubbling both during inspiration and expiration. If there is no bubbling, please look for the leaks. Most commonly, either the baby is crying, the mouth is open, or the nasal bronchs are not snugly fitted into the nose. There is leak at the interface. Then if these things have been taken care of, then only increase the flows. Usually a flow of 4 to 5 liters is enough, and usually it is not warranted to increase flow beyond 5 to 6 liters, because increased flow can lead to increased pressures, and then the complications like air leaks are more. Humidification should always be 100%, and the best way is to touch the inspiratory limb. It should be warm to touch. There should be no condensate in the inspiratory limb, and there should be some mist in the expiratory limb. Temperature should always be looked at the humidifier, and the set temperature should always be 37 degrees Celsius. Now, the first and the foremost indication of CPAP is RDS. We often have preterm babies starting respiratory distress in the delivery room itself. And it is good to use CPAP right there in the delivery room with the help of TPs. Remember that CPAP decreases the need for mechanical ventilation and need of surfactant by 50%. Therefore, all babies, preterm babies who have respiratory distress should be started on delivery room CPAP as early as possible. But once the respiratory distress is passive, do not be in a hurry to wean off, especially the premature babies less than 30 or 28 weeks from the CPAP, because CPAP not only decreases the respiratory distress, it always, by stretching the lung, it always helps in the lung growth. Babies who were started on CPAP compared to babies who were on hood oxygen showed that there was higher DNA contents in the lungs which were started on CPAP, thereby postulating that it also helps in the lung growth. And for all the babies who require CPAP for more than 1 day, especially premature babies less than 32 weeks or less than 1.2 kgs, they should be started on caffeine, preferably within the first 3 days of life. It decreases the risk of BPD and also leads to better neurological outcome. The initial settings for RDA should be CPAP of 5 to 6, and FiO2 to start with should be 30%, and then gradually it should be increased to reach that desired saturation target of 90 to 95. Now, CPAP has also been used in mucormyspation syndrome, and it is effective. The indication being that whenever the FiO2 goes above 50%, that is significance of moderate to severe MAS, and these babies can be started on CPAP as early as possible. Do not use antibiotics in mucormyspation syndrome because it is inflammation, not infection. Now, do not label sepsis as always the cause of deterioration in any patient, especially in mucormyspation syndrome. The commonest cause of deterioration in these babies is PPHN and not infection. And the easiest bedside test to pick up babies with PPHN is, first of all, they have lability of oxygen. That is, they suddenly have 30%, they are doing well on 30% FiO2. And when you do rounds or you handle the baby, the FiO2 shoots up to 60 or 70%. The other common bedside test is do a preductal and postductal saturation difference. A difference of more than 5 to 10 is usually indicative of PPHN. The thing which you have to remember in mucormyspation syndrome while using CPAP is that if the X-ray showing hyperinflated lung fields, do not give high pressures above 6. Consider mechanical ventilation early. So the setting should be start with a low CPAP of 4 and then go on to 6. If the baby is not maintaining saturation on CPAP of 6, FiO2 of 50 to 60%, go and ventilate these babies early. This is one of the papers we published in JAMA, where we showed that babies who were put on CPAP compared to hood box oxygen, the need for mechanical ventilation was drastically reduced from 25 to 3%. Also, the need for surfactant was decreased from 16 to 4%. Also, because of the less intervention, the risk of sepsis was as low as 6. And this came at no additional cost. That is, it did not increase the complication like air leak, which is often feared in using CPAP in mucormyspation syndrome. As discussed already, CPAP can also be used in apnea, but remember to use caffeine along with CPAP in these babies, and always let the baby be apnea free for at least 24 hours, and then only wean these babies from the CPAP. However, if a baby has recurrent apnea, especially those requiring bag and mask ventilation, despite giving adequate CPAP, then these are the candidates who will require mechanical ventilation. Since the lungs are normally in apnea, they require minimal pressure, that is 4 to 5, and minimal FiO2, 21 to 30%. If your baby is requiring more pressures, more FiO2, then this is not apnea of prematurity. This apnea is because of something else. And remember that apnea of prematurity is always a diagnosis of exclusion. Now, post-extubation CPAP has done wonders, especially in premature babies who are less than 32 weeks or babies less than 1.5 kgs. It decreases the risk of extubation failure by 40%. It also decreases the BPD by 20%. And one of the other interventions to decrease chances of reintubation is caffeine. Caffeine should be started 24 to 48 hours before extubation if the baby is not already on caffeine. And post-extubation, we use slightly higher pressures of 6 to 8 centimeters of water. More premature baby use higher pressures. And FiO2 is similar to the ventilator. That is, during weaning, whatever the FiO2 is on the ventilator, start with the same FiO2 on CPAP. Now, once the baby's disease process is passive, how to wean? There are two strategies which are commonly involved in weaning from CPAP. One is the pressure strategy, where we decrease the pressures gradually. Suppose the baby is on CPAP of 8, we come down to 7, then gradually to 6, then 5, then 4, and then we finally wean them off. The other strategy which is used in some of these centers is cyclic weaning, where the baby is taken off for a fixed period of time from the CPAP. And then, for example, on day 1, we took the baby off from CPAP for 4 hours. Then next day we increase the duration, that is off CPAP for 6 hours, then 12 hours, and then gradually altogether we stop. Now, if we compare these two strategies, that is pressure weaning versus cyclic weaning, it is seen that pressure weaning is better strategy. It has shown to be decrease the duration of CPAP and oxygen, and thereby it decreases the duration of hospital stay. So that is the strategy we use in our unit. That is, we decrease the pressures from the highest pressures to 4 to 5 and a FiO2 of less than 30%, and then we wean these babies from the CPAP. The other thing is that once we have weaned these babies from the CPAP, the battle is not over. Remember that 50 to 60% of the ELBW babies or babies who are less than 1.2 kgs, they will get reintubated. So always be cautious in the first 48 to 72 hours, do a proper suctioning, keep on changing the posture, keep the baby's bones for adequate ventilation of the lungs, look for any signs of increased work of breathing like apnea, tachypnea, retractions, bradycardia, and always be there with the baby for 48 to 72 hours, because that is the most critical period when these babies get reintubated, and ensure a good nutrition and good bone health for these babies. Now, when should we consider failure of CPAP? That is, if despite giving the maximal setting, that is a pressure of 8, FIF of 50 to 70%, if despite giving these settings, the baby continues to have increased work of breathing in the form of retractions, grunt, there are recurrent apneas, there is persistent hypoxemia, or there is persistent hypercarbia, then these are some of the markers of respiratory failure and babies will require mechanical ventilation. However, do not forget to use surfactant in babies with RDS before jumping to mechanical ventilation. So before jumping to mechanical ventilation, one should always ensure that we have used snugly fit nasal prongs. That is the only difference between the CPAP interface and the HFNC interface. That is, in HFNC, the prongs, they occupy less than 50% of the diameter of the external nares, whereas in the CPAP, they should completely fill the nasal orifice. So humidification and temperature are equally important as are pressures and FiO2, and always ensure that we are giving adequate CPAP and FiO2. Sometimes there may be failure of the blender, and despite setting 100% FiO2, it may be giving only 21%. Same is true for the CPAP. If the water levels are not adequate, or the water is not up to the mark, then even though you have set a CPAP pressure of 6, it may be delivering only 3 to 4. So that is also an important part of the checklist before jumping to mechanical ventilation. Now, coming to the bubble CPAP assembly, it usually has two major parts. One is the delivery system, and other is the interface, which connects and which delivers these gases at a set pressure to the baby. This is the delivery system. We'll discuss this.
Welcome, Fraser, with the.
So, coming to the different parts of the CPAP. Am I audible?
Yes, sir.
Yeah. So, add gas back to the CPAP generator.
So these are the parts of the CPAP. First of all, we have a blender which gives air oxygen mixture, and these blended gases, they move to the humidification chamber through this pressure manifold. This is the type of safety valve, that is, it do not allow the pressures to go beyond a certain limit. And then these gases pass to this humidification chamber, which is corrugated, so that the gases get enough time in this humidification chamber to pick up the water vapor and get warmed before being delivered to the baby. Then this is the inspiratory limb, which takes these gases which are humidified and vomidified to the baby. And then this white limb is the expiratory limb. In order to generate CPAP pressure, it is immersed in a water chamber to generate that pressure. So these are the parts of the CPAP system. Now, how to start the CPAP system is first, we start with the humidifier. This is the auto controlled humidifier where it is automatically regulates the temperature. This is the heater plate on the top, which is the silver, made up of silver plated, and this is the finger guard. So what we do is that we lower the finger guard and we insert this humidification chamber over it, and it is sealed in place, and we can hear a click usually when it is in place. So once it is in place and there is a click, then we take this is the port which allows the water to move into the humidification chamber. In order to decrease the risk of contamination, it is always good to attach this water feed holder directly into the distilled water bottle, which is then placed on a holder like this, so that it gets automatically filled up and there is no break of the circuit. If you fill it manually, then there is the risk of sepsis is going to increase, because every time you break the circuit, you are increasing the risk of sepsis. So it is always good to use a 1 liter distilled water bottle to get it auto refilled. Do not use other medications like fluids like saline or dextrose. That is not recommended. Always use a distilled water. And this is the bubble CPAP generator, which is used to generate pressures. Always fill the water to the level which is marked here till some of the water goes into the other chamber. And then we dip the expiratory circuit into it. And there are markings between 3 to 10. So whatever pressures you want to set, that limb should be showing, that number should be showing on the top. Now, this is the blender. One part of this green tubing goes to the blender, and other is attached to the pressure manifold. So the gases with desired FiO2 moves from that blender through this manifold into the humidification chamber. Then to connect the inspiratory limb, we have this elbow joint type of circuit, and we connect it to the other part of the humidification chamber. And then these are heater wire adapters, which are color coded. So for yellow circuit, the wire has to be yellow. And again, on inserting, you will again hear a click, and that shows that the line is in place. This is to give the heater output to the chamber, that is the heater plate, which we saw initially, to increase the temperature to the desired level. And similarly for the input, we have another wire which is again color coded, so that blue will go into the blue. Sometimes we have to turn it to get that click sound. The other part of this wire goes to the inspiratory limb to heat the heater wire. Remember, there is a corrugated wire inside the inspiratory limb, which is the heater wire, which increases the temperature of this gases in the inspiratory limb. Sometimes this heater wire may also be there in the expiratory limb. That is, both the inspiratory and expiratory can be having heated wire, but usually we see it only in the inspiratory limb. So the other part of the circuit, that is the hinge joint, this goes the V-shaped, it goes into this V-shaped notch to pick up the chamber temperature, and the other part of this wire then goes to the inspiratory limb, which completes the circuit, so that whatever temperature is in the inspiratory limb, if it is not adequate, the feedback will go to the heating chamber, and if the temperature is not adequate, it will increase the temperature till we get the desired temperature in the inspiratory limb. So this completes the circuit. So for expiratory limb, the expiratory limb is dipped into this water chamber, and whatever pressures we want to deliver, the number should be seen as above. So here, if we want to deliver a pressure of 6, the 6 should be visible on the top. So here we are giving CPAP of 6. And then we can do the bubble test, where after connecting the interface, we can block the interface or mask or short binaural prongs, and we should be able to see a continuous bubbling in the chamber. Here they are using a T type of connector which connects the inspiratory and expiratory limb. And after starting a flow of 3 liters, there should be a continuous bubbling in the chamber, like as shown in the video. That shows our flows are adequate and the circuit is complete. There is no leak. If the bubbling is not there, that means there is leak somewhere and we have to correct it before switching on the humidifier and before connecting it to the patient. So usually flow rate is around 3 to 6 liters, and usually we do not require to go beyond 6. So as we discussed, this is the method to give desired CPAP. Here, if you want to give a CPAP of 6 should be visible outside the chamber. The markings are between 3 to 10. That is, we can deliver pressures between 3 to 10. And this, then the inspiratory and expiratory limb, they are connected to the interface. Here we are using a mask along with the bonnet. And after completing the circuit, after completing the interface, we then, and after completing the bubble test, we then set the humidifier at temperature of 37 degrees Celsius, and it gives a relative humidity of 100%. Now coming to the interfaces, there are various interfaces available. The best is using a mask, because remember that neonates are obligate nasal breathers. So in order to avoid decreasing the diameter of the nares, we tend to use mask because it is fitted outside the nose. Also, the risk of nasal injury is less with the help of nasal mask. However, if nasal mask is not available, the second best is using short binasal prongs. Some units, they use alternating, that is, they cycle between the mask and the short nasal interface. These are the other interfaces which are available in the market, and depending on the unit preference, you can use any of the two. Now, the complications are always there, but if we are meticulous and we are monitoring properly, there are rare events in a good NICU. They may be device related. For example, if we are giving too much of pressures, there can lead to air leak. Because of the high pressures, there can be increased intrathoracic pressure, which decreases the venous return to the heart, leading to the decreased cardiac output, long CRT. Other important and common complication is regarding the related to interface, that is nasal injury and nasal trauma. So the best thing to avoid this is use a mask, and in between, during each shift, you should remove the mask. If there are signs of redness, blanching, you should gently massage the nose to relieve the tension on the nose, and always be meticulous in using CPAP. Just like any other procedure, this can also lead to increased risk of sepsis. So you should always maintain asepsis and always use distilled water to fill the chamber for delivering the pressures. Other complications can be CPAP belly, that is, all babies who are on non-invasive or invasive mechanical ventilation, they should have an OG tube in C2 to vent off the excessive gas which goes into the stomach. Otherwise, it will lead to abdominal distension, which is a passive phenomena, but often it leads to stoppage of feeds, thereby lead to malnourishment of these babies. The other complication which we had reported in the literature is known as Pandita's fallacy. It was reported a few years back. We tend to observe that babies who are started on CPAP, they tend to have facial palsy, and usually this is a benign phenomenon. It usually recovers of its own. The postulate which we postulated is that because of the tight interface, it presses on the stylomastoid foramina near where the facial nerve exits and causes pressure paralysis. And after removing CPAP, these babies, their facial palsy recovers between 2 to 3 weeks. So this was reported in BMJ and was well accepted. Then the other hand, problem is with the units, like in majority of the units in developing countries, is sepsis. So always be meticulous in hand washing, using hand rub and disposable circuits wherever possible. Always use EBM, at least colostrum, as a mouth paint if the baby cannot be fed. Always give EBM. Remember that prevention is always better than cure. Now coming to the cost effectiveness, when we compared cost effectiveness of CPAP versus nasal high flow, especially in level 2 centers like SNCUs. It was shown that CPAP is much more cost effective if you have to choose between either HFNC or CPAP. However, if you have both in the unit, it is good because majority of the babies who will fail HFNC, they can be rescued with CPAP. But if you have limited resource and you only have money to buy one machine, always go for CPAP. Now, this is the monitoring chart which we use in our unit. And the common things which we monitor for babies on CPAP is vitals, SES score, CRT, CPAP pressure, saturation, FiO2, flow rate, urine output, and abdominal girth. This is simple and easiest to maintain, and monitoring should be more frequently in babies who are sick. Now, other major question is between which to use, CPAP or HFNC as a primary mode. The answer to majority of the extent is answered by this systemic review, which was published only last year, which had around 1800 babies. It showed that the risk of failure is more with HFNC to the tune of 34%. However, there are less risk of nasal injuries with HFNC. There was no difference in mortality or mechanical ventilation. So for premature babies who are less than 32 weeks, it's always good to use CPAP as primary mode. In more mature babies or post-extubation, you can use HFNC. So this is the flowchart algorithm. Any preterm baby who has respiratory distress or apnea should be started on CPAP. You can use HFNC as primary mode, but for older babies, that is more than 32 weeks, because the risk of failure is more. However, these babies, even if they have failures, they can be rescued with CPAP. However, if there is CPAP failure, the next modality before jumping to mechanical ventilation is non-invasive mechanical ventilation. NIV. These days, we also use nasal HFO. If baby fails on NIV, baby has already received surfactant, then one should think of ventilating these babies. And post-ventilation, especially in VLBW babies, we can use either of CPAP, NIV, HFNC, all are equally effective. But in babies who are less than 28 weeks, NIV has been shown to be more effective compared to CPAP and HFNC, because the rates of reintubation were much lesser in babies who were extubated to NIV. So the take-home messages for today's lecture is that CPAP is effective, safe. It remains the backbone of the respiratory support for neonates. It is not only effective, but it's also safe. Remember that CPAP and surfactant go hand in hand, and both should be used together in babies with RDS. In first 2 hours of life, that is early rescue, surfactant is most effective. Complications are there, but if you are meticulous, you are good in monitoring, it's a rare event in today's modern NICUs. So remember to focus on ventilation rather than ventilation. Gentleness is a virtue which is stronger than majority of